I'm really delighted to introduce our next speaker, perhaps the highlight of our panel, without offending anybody, Honorable Dr. David Shulkin. Dr. Shulkin is an internist. He had the opportunity to run a hospital system, ultimately to run the Veterans Administration. And he's going to speak to us on the topic of the trAIn is leaving the station. Dr. Shulkin.
Well, thank you, Dr. Freed. It's humbling to be speaking on a panel of surgeons. As Dr. Freed said, I'm an internist, and so I don't look at many surgical cases, so these videos are really cool. My last time that I remember seeing this was as a medical student trying to look into the operative field, but I was too small. I never really looked inside and figured I better not do surgery. How many of you are videotaping or videoing your surgical procedures? Wow, a lot. Okay. How many of you would like to, but your administrators don't want you to? A few. Okay. Oh, that's interesting. As Dr. Freed said, I spent my career running healthcare systems, pretty large healthcare systems in the Northeast. And then I got a call from President Obama one day saying, would you help us at the Department of Veteran Affairs? We're having some problems. And my perspective on things changed. What I'm really going to talk to you about today is what you're hearing up here, whether this is the right direction for healthcare to go, and whether it's actually going to happen, whether this type of new way of looking at surgery is likely to occur. And my perspective on things really changed once I went into government and into public service. I was confirmed before Congress twice, 100-0, and then found myself in a very different situation. Usually, when I was talking about surgery, when I was running private hospitals, it was behind a closed door. It was some complication that happened, some type of medical error, and I could usually keep it within the realms of the CEO's office. It wouldn't become public. Once you're a public official and there's a big problem, even a veteran who dies from a surgical complication, it becomes a public issue. And so I would find myself all the time at the White House having to talk about and identify our problems that we were having in the Department of Veteran Affairs, or often called before Congress in a hearing to talk about a specific problem or a specific patient. And basically what I began to learn is that it was important to talk about the problems, not to hide from the problems or make excuses about them. But I actually began to take the opportunity to go before the press, to use the White House as a forum, to talk about these are the reasons why we continue to have these problems year after year in the Department of Veteran Affairs. Because if you don't tell people what the problems are, you don't know how to fix them, people don't know how to help you fix them. And so I'm a big believer that a lot of what we need to do in healthcare has to be to speak about the problems and be transparent. When I first came to the Department of Veteran Affairs in the Obama administration, as I mentioned, President Obama asked for my help because there was a wait time crisis. I don't know how many of you remember that. The veterans were coming back from Iraq and Afghanistan, Vietnam veterans getting older. The Department of Veteran Affairs just couldn't handle the volume, and veterans weren't being seen for long periods of time, and allegations of veterans dying. When I first took the job, there were these billboards outside every VA medical center. So when you walked into the VA, if you were a surgeon or an employee or a patient, you would see these signs saying that the Department of Veteran Affairs had lost the trust of its veteran community. And so my job was to fix the wait time crisis. We ultimately did fix that. We went to same-day appointments across the entire United States and did a number of things to fix the wait time so that in the VA today, wait times are statistically far better than what you would find in the private sector. But the way that I thought about the problem was that usually when you fix a problem, there's a lot of energy to fix it, and then once it's fixed, you take your eye off of it, and a couple months or years later, you're back to where you were, crept back. So I decided the only way to make sure that didn't happen was to publicly publish the wait times in the Department of Veteran Affairs. Today, the VA would be the only health system in the country that I'm aware of that publishes its wait times publicly so that you can go on and see what those wait times are. And that's a transparency strategy to try to keep healthcare in the Veterans Administration at the level that I believe it should be at. When I also entered the VA, we had another crisis going on that all of you are probably familiar with, and that was the opioid crisis. There literally were millions of veterans on long-term opioids because 60% of veterans have chronic pain, much higher than the general population. And once again, I turned to transparency. I published the opioid prescribing rates of every VA medical center in the country. And not surprisingly, just like what Dr. Wolf was showing, there was huge variation. There were some VAs, like this one in Oregon, the Roseburg VA, 20% of all veterans were on opioids. And then there were other VAs, like the Cleveland VA, where 3% of veterans were on opioids. And so learning from those best practices, but shining the light with this type of transparency was really part of the large reduction that we've now seen in opioid use in VA. Now, I always said that the problem in the department, or the many problems in the Department of Veteran Affairs, really has not ever been because they don't have enough money. The VA is the second largest government organization. In 2020, the budget was $220 billion. This year, or in fiscal year 2022, a federal year, it's $245 billion. There's plenty of money, but the problems are because the systems just aren't running the way that they should be. And so once again, I turned to transparency. The VA was always good about publishing outcomes. NISQIP, as you know, had its origin from the VA. But what VA would do is publish one VA's outcomes compared to another VA. But the way I looked at it, if you were a veteran in Detroit, you weren't looking to go to the Detroit VA or the Miami VA or the San Diego VA. You were probably looking at the Detroit VA or Henry Ford or Beaumont or the University of Michigan. So I published all of the quality data for veterans where the VA would compare itself to the local hospitals, the private sector hospitals. And that again, I thought, was the strategy of shining a light to improve the quality for our country's veterans. In terms of making healthcare better and allowing patients to understand what happens to them, I took a very patient-centric approach. And using telehealth, allowing veterans to be able to get care more conveniently, to be able to actually have their families share in those visits. Much of the telehealth regulations that occurred during the public health emergency that we're in now were because the Department of Veteran Affairs did this first, well before the pandemic. We were using telehealth at scales well beyond anyone in the public sector. And even when we had regulatory barriers, it was the first time that I ever practiced telehealth as a physician when I went to the VA. You can see I brought my telehealth equipment to the Oval Office and asked the president for some regulatory relief and help so that we could do that for people across the country. In the bottom picture, you can see that the vision that I had, I was not trying to teach the president how to use Twitter or not to use Twitter. Believe me, he did not listen to me. But I was trying to move all of healthcare onto the mobile phone so that patients could have access to their health care and have access to even potentially their surgical procedures. Probably the most controversial thing that I did when I was in the Department of Veteran Affairs had to do with the use of information. Many of you may have heard of the blue button. The VA was the initiator of allowing the veteran to have access to all of their health care data. Any veteran can download their data and take it with them to be able to go to any other provider that they want to go to. And that blue button methodology is now written into the CMS regulations in the CARES Act, so that that's coming to all patients across the country as that begins to get implemented. But the other thing I did was that I moved away from the VA's own homegrown electronic health system to a commercial health system, in this case the Cerner system, in order to create the interoperability of data that we're talking about here, so that that data can be shared freely and patients have access, physicians have access, that there's not this information blocking that occurs in all of our hospitals because of the electronic health record companies. And so I'm just going to end by talking about where I think the future is coming. I hope that you understand that I'm a strong believer in transparency, in patient-owned healthcare, and data interoperability. When you take a look at what we're hearing up here, the last frontier, in my view, is where you guys spend your time in the surgical operating room. Being able to have transparency about what goes on in those procedures, how we can get better, how we could eventually share that data or share those videos with our patients, and really making the whole healthcare experience open and transparent, I think is the way that you get to those best practices that Dr. Wolf was talking about and making healthcare better. So I'm going to stop there.
To my American friends, I practice the Canadian system in the context a little bit different, and talk about routine video recording. The first reaction I get is, oh, the lawyers are going to love this. And so how do you balance the spirit of transparency if people actually believe in the benefit of this, with the concern that this will be put to use in a way that will actually discourage them from doing that?
I think the excuse of creating situations that will lead to lawsuits has been an excuse for a long time. And again, I don't want to completely focus on the Department of Veteran Affairs, but the Department of Veteran Affairs first came out with a policy about being honest and telling patients when there's a mistake. And in the private sector, we thought, that's crazy. You know, if you go and you tell a patient that you made an error and that maybe it killed the patient, you're going to be inviting liability. So the VA went out and did this. And by the way, you can sue the federal government, and the VA does get sued. And what we learned from that experience was actually lawsuits went down, not up. When you try to hide things from patients and families and then they find out, then they're angry and then they really want to come at you. So that practice has now spread into the private sector. And I think in most examples where you try to do the right thing and you use it to improve care, there may be some short-term pain, there's no question about it, but I think that it almost always turns out to be that those fears about lawsuits are probably overreactions, and if you can improve and prevent, which I think is really what Dr. Wolf was talking about, how do we use this to learn to do a better job, that's actually going to be a reduction of liability.